All right. So we'll go ahead and get started. It's 4 o'clock. Thank you all for joining us for this special session. It's really my pleasure to introduce Dr. Michael Voss as our guest speaker today. Michael, as many of you know, as Mickey is currently a second-year fellow in endocrinology at UW-Madison, and Mickey obtained his MD at the Medical College of Wisconsin, and that was followed by residency training at Indiana University. While he was a medical student here at MCW, he conducted basic science research in laboratory of Dr. John Corbett, and where he studied antiviral response of macrophages and pancreatic beta cells to identify triggers of autoimmunity in type 1 diabetes. He was the recipient of Endocrine Society Outstanding Medical Student Achievement Award in 2017 while he was here at MCW. He continued his interest in type 1 diabetes during his residency training and fellowship training with ongoing collaborations with Indiana University with looks like a couple of publications. One is in review. He has a strong CV for someone who is so young in his career, and we are really glad that he's here today to explore future employment opportunity with us. He's going to talk to us today about the title of his talk is Finding the Sweet Spot, Cardiovascular Risk in Type 1 Diabetes. I have to say that is the title inspired by Samantha Pavich?
I think we threw around titles when I was talking with her about it. So yeah, that was kind of how we came up with it.
She said that you always have to have a funny title for every talk. So when
I
I read
agree.
that you have Sam's influence on your title.
Yep, I agree. You got to keep it interesting.
Yes. So with that, go ahead, Nikki.
All right, so let me share my slides here. Right, and can everyone see my slides and hear me okay? And it's not in presenter mode?
It's not in presenter mode right now.
Perfect. Can you see the full slides though?
Yes, but you have to
All right.
switch the view.
Oh, it is in.
No, you're
you guys are seeing the
you are in
presenter
presenter mode, Mickey.
Got it.
Yeah,
How about now?
there
Is
you
that
go.
better? All right. All right, so as Dr. Kadami, thank you for the warm welcome. It's good to see so many familiar faces. Glad everyone is doing well. I left obviously under different circumstances than we're living through now. But today I want to talk about finding the sweet spot, so optimizing cardiovascular risk in type 1 diabetes. So with that, I'll get started. So I don't have any disclosures. Here are my objectives. So we're going to review mortality and cardiovascular risk data in type 1 diabetes, and specifically examining how current treatment goals affect cardiovascular outcomes in type 1 diabetes. And then we'll also take a look at specific risk factors to cardiovascular risk and how they apply specifically to type 1 diabetes. And then at the end, we'll sort of discuss cardiovascular risk reduction in type 1 diabetes and explore some of the data in support of off-label use of non-insulin agents in type 1 diabetes. So as we're all familiar with, type 1 diabetes is an autoimmune condition. It's a T-cell mediated pancreatic beta cell destruction that ends in insulin deficiency and resultant hyperglycemia. Unfortunately, to the dismay of many, we still don't understand the exact pathophysiology, and it's sort of a complex interplay between genetic factors, environmental triggers, the gut microbiome, metabolic disturbances, and the innate and adaptive immune systems. And so just touching on how common type 1 diabetes is, so 1.4 million adults above the age of 20 in the US have type 1 diabetes, which makes up about 5% of all the diabetes diagnosis in the US. About 18,000 children and adolescents in 2014 and 2015 were newly diagnosed type 1s, and this is based on the search cohort data. And in 2050 alone, it's estimated that up to 5 million people in the US alone could have type 1 diabetes. And this is sort of represented by these graphs showing the increased incidence of type 1 diabetes over time. And as I mentioned, having left under different circumstances, unfortunately, we don't really know what the long-term ramifications of COVID are going to be, and is that going to see an even larger jump in type 1 diabetes incidence? We'll have to see, hopefully not, but certainly something that we'll have to keep in mind. So we're all familiar with complications from diabetes and the significant healthcare cost burden that it causes. In 2017, it was estimated there was $327 billion in U.S. healthcare costs that went to diabetes and complications from diabetes. And obviously, for the purposes of today, we're going to focus on cardiovascular disease. So this is mortality data from the Swedish cohort registry, where they have sort of cross-sectional analyses of the population looking at type 1 diabetes. And what I want to highlight with this is really in this bottom right-hand corner, looking at death from cardiovascular causes. And across all age groups, male and female, we see that there's a significantly increased cardiovascular risk across the board. And I don't think that's surprising to anyone. But I think what is a little bit jarring is looking at the risk in the 18 to 34-year-old population, both in males and females, and how much higher it is compared to the general population for the age and sex match controls. The other thing that jumps out at me is when you look at sort of the risk and the relative risk, looking at female versus male, the risk to females with type 1 diabetes is actually much higher, which is sort of flipping our typical thought process when we're thinking about cardiovascular disease, typically more common in men, but it sort of reverses in type 1 diabetes. So this is more data from that same cohort, and I just want to highlight looking at A1C data and the effect on cardiovascular mortality. And when you look at it, our goal is less than 7%, right? We all know that. And even when you're achieving those goals, you still see a threefold increase in cardiovascular risk just for patients with type 1 diabetes. And obviously, as the A1C control worsens, that increases much more rapidly as well. Then when you look at microalbuminuria versus no microalbuminuria, the risk is still high in folks who don't have any evidence of early kidney damage from diabetes. But when you get microalbuminuria, the increased risk is doubled. And that was sort of striking to me when I was preparing for this talk, looking at this and just sort of the risk that's associated with this and how quickly it can increase. So looking at this just from one other perspective, so again, this is the Swedish Diabetes Registry and looking at 27,000 type 1 diabetes patients versus 135,000 age and sex match controls. And this is looking at and comparing sort of the age of type 1 diabetes diagnosis on the x-axis versus expected median survival. And you can see in the matched controls, in the red, compared to the type 1 diabetes patients, those who are diagnosed early on in life have a significant reduction in their life expectancy. And if diagnosed before the age of 10, this can amount to around 16 years life years. And it's a little bit more so seen in females, unsurprisingly, given the longer life expectancy that we see in females compared to males. If diagnosed after age 20, while it's a little bit better, it's still a 10-year life expectancy difference. So there's a significant survival disadvantage for those who are diagnosed earlier in age with type 1 diabetes. This is a busy slide, and what I want you to focus on here is females are in red and males are in the teal color. And when you look at some of the middle panels, cardiovascular disease, coronary heart disease, acute MI, you see obviously the risk is increased across all age groups in males and females with type 1 diabetes. But again, looking at the red bars compared to the teal, it's significantly increased in women compared to men. So where does all of this increased risk come from? And I think it comes from sort of lifelong atherosclerosis and abnormal metabolism, right? So you have a lifelong exposure to increased substrates, glucose, free fatty acids, lipoproteins. There's increased inflammation, both from oxidation and glycoxidation. You lose anti-atherogenic factors in nephropathy, and then possibly, which we'll discuss in a little bit more detail later, dysfunctional HDL particles. Macrophage dysfunction from retained cholesterol in the vasculature, endothelial dysfunction and decreased nitric oxide. And all of this is on top of that, we compound that with obesity. You know, I think a lot of people picture type 1 diabetics as otherwise young, healthy, skinny, fit patients, but that's not the case. And we know that later on in life, type 1 diabetes patients develop becoming overweight as well as obesity, and that just compounds everything and amplifies it all the more. So how do we prevent cardiovascular disease in type 1 diabetes? Obviously a lofty goal, but what can we be doing to reduce patients' risks? And we'll focus mostly on glycemic control, cholesterol reduction. We'll look a little bit at renal protection, both in medications and blood pressure control. And are there other protective medications that we can use in this population to reduce their risk of cardiovascular disease? One that I think frequently gets overlooked in this population because we focus so much on glucose control is smoking cessation. And unfortunately, given the time, we won't have time to discuss sort of other heart healthy diets and physical activity, and then some of the more controversial studies looking at how to do coronary artery disease screening in this population. So let's talk about glycemic control. So this is a study that we're all familiar with. It's the Diabetes Control and Complications trial that was done in '93. And it looked at type 1 diabetes patients either with no prior complications or mild retinopathy and nephropathy at baseline. And they randomized them either to intensive A1C control with an A1C goal of around 7% versus conventional therapy, which was around an A1C of 9%. And they followed these patients in these treatment groups for about 6.5 years. They had about 1,400 patients, and their average age was 27. And so you'll look here, you look at the intensive group, which is the square line, which is the top lines in both graphs, both charts. And you see that there's a reduced incident microalbuminuria on the left, and there's less progression in those who were in the intensive treatment group. And so this has been the mainstay of our treatment in terms of reducing risk of progression to CKD in diabetes patients, and has formed sort of the basis for our A1C targets of being 7% or less. So looking at this patient population in follow-up, so after DCCT, the participants returned to their community providers. They went back to their normal regular providers, and they have follow-up for these patients now, about 93% of the original population, for up to about 30 years. And when they went back to their regular primary care providers or endocrinologists, their A1C differences between the two groups dissipated. But the benefits persisted in the intensive group. So those who were in the intensive group in the study, regardless of their A1C later on afterwards, they still had reduced incidence of microvascular complications as well as progression, and they also have a reduction in cardiovascular events. And this is shown in these charts here. And when you look at the left, this is any cardiovascular event, the conventional group being blue and the intensive treatment group being in red. And you can see certainly a survival benefit of less cardiovascular events in those who were in the intensive treatment group that lasts many, many years outside of the actual intensive therapy that they received in the DCCT. Additionally, you see this with regards to the first major adverse cardiac event, which is non-fatal MI, stroke, or other cardiovascular disease. And you see a survival benefit in the intensive group sort of lasting well out past the DCCT. Looking at it another way, when you look at microalbuminuria and A1C, and you adjust for both of those variables, you can see that as you get further away from the actual trial itself, there's still a survival benefit, but it is declining over time. Okay, so at 20 years, there was about a 40% reduction in cardiac events versus now in the most recent iteration of the EDIC study, about 32%. So the legacy effect is still there, but it certainly is lessening with time. When you adjust for these variables, A1C more significantly so than micro or macroalbuminuria, you eliminate the intergroup differences. So what does that mean? What am I saying when I say that? When you look at the hazard ratio for cardiovascular risk in those with sustained microalbuminuria, you see that there's a hazard ratio of about 2.28. When you adjust for eliminating microalbuminuria, that difference dissipates. And even more striking is when you look at A1C increase or decrease, these are sort of weighted A1C values between the DCCT and EDIC follow-up. And you see as the A1C goes up, unsurprisingly, their cardiovascular risk rises. And when you decrease their A1C, their cardiovascular risk goes down. Then when you adjust for A1C, you see that there is no difference at all between the two groups of hazard ratio. So all of this just sort of points to what we, I think, all understand is that there's a clear survival benefit in achieving glycemic targets in type 1 diabetes. And maintaining these glycemic goals earlier in life seems to yield a legacy effect. We can argue about how much of an effect that truly is and whether or not it's real and how significant it is, but it certainly seems like there is an effect. And that plays out in reduced microvascular complications as well as cardiovascular events. And I'd be willing to bet that the benefits are likely amplified with a longer duration of glycemic control being at goal, right? So this was only 6.5 years achieving target A1C, and then they let them ride and you still see this effect. But what happens when you keep A1C at goal for longer than that? I would expect that you'd see a larger benefit. So how are we doing in meeting these goals, right? So our A1C goal of 7% or less. This is data from the Type 1 Diabetes Exchange Registry, both in 2010 to 2012, and then again in 2016 to 2018. And this is a survey that asks Type 1 diabetes patients across the US sort of demographics. What is your A1C? What type of insulin are you using? Are you on a pump, CGM, and the like? And we can see that maybe we're not doing as good as we think we are when we're looking at achieving A1C targets. The orange line being from the 2010-2012 data, and the blue-gray line being from more recently in 2016 and 2018. And obviously, this is a very high-risk population in the 10 to 20-year-old patients. But even as you get out into 40, 50, and 60, the mean A1C across these registries, we're not hitting our targets. It's reported that about 17% of kids are reaching their target and only about 21% of adults are reaching their target. Just to bring up sort of what are people using in terms of type 1 diabetes therapy now, these 4 bars are grouped by age. So under 13, the middle grouping being 13 to 25, and the right grouping being older than 26 years of age. And you have average A1C on the y-axis. And so these black bars are representative of patients who are just using multiple daily insulin injections alone with finger stick glucose testing. The horizontal bars are injections with CGM, and you see certainly a benefit in terms of A1C reduction with just using CGM alone. And then when you move to the white bar, this is pump therapy with finger stick glucose checks, and then the diagonal bars being pump plus CGM. And you can see, obviously, as we use these different therapies, and this was from 2016, 2018, now with some of the closed loops and better technology, better sensors, are these effects amplified. And just to highlight, I think as we're all aware, obviously there's significant access issues that we have in terms of getting patients pumps and CGMs. And certainly that plays a role in terms of racial differences in access for medical care for our type 1 diabetes patients. So something that we certainly need to keep in mind. So moving on from glycemic control, what about lipid management in type 1 diabetes? So this is going back to data from the Swedish registry looking at sort of all-cause mortality and cardiovascular death and sort of breaking it into different categories, subgroups. And it's looking at patients who were reported to be taking statins and whether or not there seemed to be a benefit from cardiovascular risk standpoint. And certainly there does seem to be a benefit from statins in type 1 diabetes patients in terms of reducing cardiovascular risk. But again, this is just an observational study. What about randomized control trials? Do we have any in type 1? And the answer is no. And this is going to unfortunately be a common theme as we move through the rest of this talk, because we just don't have the studies to back up what we're going to do to try and to reduce risk of cardiovascular disease in type 1 diabetes patients. So this is a meta-analysis that had 170,000 patients of all the large statin outcome trials. And look at what you have for type 1 diabetes. You've got 145 and 192. So, it's hard to make any judgments based on that. Certainly it looks like maybe there's some benefit to it, but again, large error bars because it's just such a small population. So what are our LDL targets for primary prevention in type 1 diabetes? So I'm not talking, obviously, people that have existing cardiovascular disease. This is primary prevention, because obviously that's our goal, is preventing any of our type 1 diabetes patients from developing cardiovascular disease. So looking at sort of the US society guidelines, when you look at ages 20 to 39, you can consider starting the statin with the goal being less than 100, LDL less than 100, if they have multiple ASCVD risk factors. That's the ADA. If they've had type 1 diabetes for greater than or equal to 20 years or have any microvascular complications, we should start a statin. That's from the American College of Cardiology and the American Heart Association. So a little bit different there, a little bit more aggressive from our cardiology colleagues. When you get to age 40, anyone with type 1 diabetes, it's recommended starting a moderate intensity statin. And that is actually in line with all 3 of those organizations. So that makes it a little bit easier. Once you hit age 50 to 70 and have risk factors, then they bump up the recommendation to a high intensity statin. And if their 10-year ASCVD risk is greater than or equal to 20%, they recommend adding ezetimibe to a statin to reach target goal. And now with the advent of the PCSK9 inhibitors, those can be recommended as well to help achieve these targets. But again, there's no significant data to suggest looking at type 1s with the PCSK9 inhibitors. Let's look at the European guidelines because they're a little bit different. They focus more on sort of a risk stratification and then deciding whether or not statin therapy is indicated based on their perceived risk. And I would argue that they're a little bit more aggressive than we are here in the U.S. They moderate risk patients. They basically say consider starting a statin with target being under 100, basically the same. But their moderate risk is age under 35 or type 1 diabetes duration for less than 10 years and no risk factors. So that's the moderate risk group. They're under 35 years of age, they've had diabetes for less than 10 years, and they have no other risk factors. Their high risk group is anyone who's had type 1 diabetes for over 10 years and no complications. That's their high risk group. So diabetes for 10 years and no complications. And in those folks, they recommend starting a statin with a goal LDL being under 70, along with a greater than equal to 50% reduction from baseline. What's their very high risk category? This is anyone who's had type 1 diabetes for 20 years, has any microvascular complications, or has 3 or more cardiovascular risk factors. So you can see how they escalate therapy much faster than we do here based on the current guidelines that we have. And they're looking at the same data that we have and just being much more aggressive, I think. The same is true, I think, for the Canadian guidelines. They recommend starting a statin if they're over age 30 or they've had type 1 diabetes over greater than or equal to 50 years. So again, most of these other societies are quite a bit more aggressive than the ADA and a little bit more aggressive than the American College of Cardiology. So a quick word on ezetimibe, because I was throwing that around in there, and I think someone listening in on this talk today is fairly familiar with this data, but this is looking at ezetimibe in type 1 diabetes. I'd also looked at type 2 diabetes, but focusing on the type 1. Ezetimibe, as you know, inhibits intestinal absorption of cholesterol, and there was a small study that Dr. Kadambi was involved in looking at type 1 diabetes patients that were taken off of any lipid-lowering therapy for 4 weeks, and then they did a crossover study looking at simvastatin for 6 weeks and ezetimibe versus ezetimibe for 6 weeks with a 4-week washout. And interestingly, ezetimibe lowers LDL cholesterol by about 32% compared to only 15% with simvastatin. Now, why might that be? And I think what we're starting to understand more and more as more data, as more studies are done, is type 1 diabetes cholesterol metabolism is different. And unfortunately, we just don't have any cardiovascular outcome data to support interventions despite sort of this known difference. And something else I wanted to highlight along with the LDL cholesterol is then looking at HDL cholesterol. So this is from the SEARCH study, which is a cohort study where a couple centers in the US looked at children ages 10 to 22, had to have had diabetes for type 1 diabetes for about 4 years, and they got fasting lipid panel results. And what I'm highlighting here is you look at HDL cholesterol under 35 milligrams per deciliter. And the incidence goes down with worsening diabetes and worsening diabetes control. So the control group is this white bar, and they have about a 10.3% of that population has an HDL under 35 versus 7.6% in the well-controlled type 1s versus only 5% in the uncontrolled type 1s. So why would that be? Why is that significant? And so more and more data is starting to come out that whether or not HDL is truly protective as we think it is in type 1 diabetes. And there's evidence of reduced HDL function, as well as some data suggesting that this is maybe even pro-inflammatory or atherogenic in type 1 diabetes. And this results from a number of different reasons that I think aren't well understood at this point. But the composition of the HDL particles is different. They have reduced phospholipids, increased glycosylation, reduced macrophage cholesterol efflux in the vasculature, impaired anti-inflammatory and oxidant effects, and possibly increased carbamylation. There was a study that just recently came out looking at this in type 2 diabetes and sort of how this might be inactivating for the HDL particles. And why this happens, we don't really know. Genetic factors, maybe. Could this be sort of a product of exogenous insulin and effects on lipoprotein lipase? Maybe, but we'll have to stay tuned and see what comes of this. So quickly looking at blood pressure targets, just to summarize, there aren't any for type 1 specific targets. Unfortunately, all of the data is based on type 2. The Accord trial being the big one, looking at 4,000 patients of A1Cs over 7.5%, ages 40 to 79, and those with existing cardiovascular disease or multiple risk factors. And they followed them for about 5 years, and their target, systolic blood pressure of under 120 or under 140. And as you can see by the graphs on the right, there's really no significant difference between the group, and there was actually more adverse events in the 120 millimeter systolic mercury target group. So the intensive group had more adverse outcomes. So tobacco use, I think we talk about this, but we kind of overlook it maybe, and maybe we should be making more of an emphasis in this. But I think this is actually some positive data that shows that we are doing at least a better job than our colleagues in Europe. So this is data looking at smoking in the type 1 diabetes exchange registry, and then a similar cohort in Austria and Germany. And when you look at this graph, you see different age groups, 18 to 25, 26 to 50, and over 50 years of age. And the black bars being the European cohort, and the white bars being the type 1 diabetes exchange registry. And you can see that we're about half of what the European cohort is reporting in terms of active smoking. And the reason I bring this up is because within the type 1 diabetes exchange cohort itself, you see about 20% are reported as being former smokers and 72% are never smokers. So that's certainly a positive. And the other thing that's interesting is just based on smoking alone, there's about a 1% difference in A1C versus those who have never smoked before. So certainly something that we really just need to pay very close attention to. So just kind of summarizing all of those risk factors that we just talked about, this is, as we're all familiar with, the ASCVD risk calculator from the American College of Cardiology. And I question whether this is applicable in type 1 diabetes, because as we talked about, there's a lot of different variables that apply to this group in particular. So their current age goes in there, but what about age of type 1 diabetes diagnosis? I think that data from the Swedish cohort is pretty remarkable in terms of risk of cardiovascular disease based on age of diabetes diagnosis. Again, duration of diabetes, not just do they have diabetes or not. HDL cholesterol, we think it's protective, and that's sort of been the mainstay, the main thoughts in the cardiovascular risk reduction world, but is it abnormal in type 1 diabetes and maybe not as protective as we think it is? LDL cholesterol and hypertension, yes, these are important things, but we don't have targets specifically for our type 1 diabetes patients, and we're extrapolating from data from the general population and type 2s. Are they on a statin? And I think we kind of talked about this again. There's not significant data to support this, but should we be starting these and be more aggressive in type 1 diabetes patients who've had it for X number of years and starting it at younger ages than we normally would? Nephropathy isn't even on here, right? So we know that increased microvascular complications it confers increased risk of macrovascular complications and heart attacks and cardiovascular disease. So this is the steno calculator. I'm assuming most of us are familiar with this, but this is sort of trying to get at those questions that I was raising. It's trying to come up with a risk calculator that stratifies specifically type 1 diabetes patients who are a very high risk population, as we've talked about, for cardiovascular disease. And you can see albuminuria is included in here, exercise is included, duration of diabetes. And so it gets at some of these. Unfortunately, this has not been validated for treatment. And so as of yet, we don't really have something that we can use with good reliability to sort of help guide us in terms of when to start treatment for patients. So there are a few studies that are looking at this in terms of validating it, but I think unfortunately right now we can't really use it in that aspect. So is there anything else that we have for prevention of cardiovascular disease and type 1 diabetes? And the answer is maybe. So looking at some of the non-insulin agents in type 1 diabetes, metformin, the DPP-4 inhibitors, the GLP-1s, and the SGLT2s, which have gotten a lot of popularity in recent years for renal protective and cardioprotective mechanisms. And just to mention pramlintide or amylin, this is technically it is the only non-insulin FDA approved agent for type 1 diabetes. And there's really only modest improvement in glycemic control, but otherwise there's not a significant cardiovascular benefit. The reason I bring that up is because if there's, if we're using this in our type 1 diabetes patients and we see a decent improvement in glycemic control, we know that that translates into better cardiovascular outcomes. So certainly in that realm, it has its use. But outside of that, there's really no significant benefit to it. So looking at metformin in type 1 diabetes, the removal trial was the best trial looking at this. They looked at adults with type 1 diabetes for at least 5 years with some cardiovascular risk factors, and they randomized to full dose metformin versus placebo. And their primary outcome was looking at carotid artery intermedia thickness, and this is sort of a surrogate marker for cardiovascular disease. You can see on the left, there was initially a difference and a reduction in A1C when they started the metformin, and that sort of went away during the follow-up period, and there was no significant difference. And the same is true for the carotid intermedia thickness. There really isn't any significant difference in the metformin versus placebo group. So doesn't seem to be much cardiovascular benefit. Granted, it's a short study, and we don't have sort of a long-term study for this in type 1 diabetes. What about the DPP-4 inhibitors? So this is a table from a 2018 meta-analysis looking at reduction in A1C in type 1 diabetes patients. And as you can see, there really isn't much of a trend towards favoring treatment. There wasn't sort of significant reductions in A1C. And then we also have the large cardiovascular outcome trials that were done in the type 2 diabetes population. And again, in those populations, there was no cardiovascular benefit from these agents. And so given both of these two pieces of information together, I think it's fair to say that there's really not a role for these agents in the treatment of type 1 diabetes, given that there's no cardiovascular benefit and there's minimal, if any, effect on A1C. What about the GLP-1 receptor agonists? Again, most of the data is in type 2. This is a meta-analysis of all of the large cardiovascular outcomes looking at the GLP-1 agonists. And I highlight the LEADER, SUSTAIN, and REWIND trials, which are sort of right here, smack dab in the middle, because we do actually have some data that we're going to talk about in a second looking at these drugs in type 1 population. And when you look at these, certainly from a 3-point major adverse cardiac event standpoint, there certainly seems to be a benefit from these agents. Maybe less so in terms of cardiovascular death, but certainly shaded towards the treatment benefits. And so while we know that GLP-1 agonists significantly reduce MACE, whether or not they have a significant survival benefit, not quite as strong in terms of data. So what about these agents in type 1 diabetes? So there's a couple of studies that have looked at this. They're short studies and they're not cardiovascular outcome driven, but looking at A1C. And so exenatide was looked at, this was published in last November, and they looked at type 1 diabetics with and without detectable C-peptide. So about 42% of the enrolled participants had detectable C-peptide. And they looked at 2 micrograms weekly versus placebo for about 24 weeks. Their primary outcome was A1C reduction, and as you can see from both of the graphs, there really is not much difference in those with C-peptide or without C-peptide. So there was some benefit to weight loss, and I'll get into that more in a couple of slides because I think that's where some of these medications are going to start to play a role in this population. So the GLP-1 agonists in type 1 diabetes, looking at liraglutide, 1.8 milligrams daily injections. And there's 2 small studies, I believe this was in Denmark, where they looked at sort of the A1C reduction. And again, pretty minimal reduction in A1C, only about 2.25%. They did note maybe modest reductions in total insulin total daily doses, about 6 units, but again, significant weight loss of around 7 kilograms. They went back and did sort of subgroup analyses and looked at cardiovascular risk factors in overweight type 1 patients who were enrolled in this study, and they didn't see much difference in terms of heart rate, carotid intermedia thickness, or blood pressure. So looking at dulaglutide or Trulicity in type 1 diabetes, so this again is looking at patients with residual beta cell function, so detectable C-peptide. This study was finished in March of this year. Unfortunately, I looked yesterday and there are still no posted results. This is done in France, so stay tuned there. And then there's another group in Buffalo, Paresh Dandana's group, that are currently recruiting, looking at insulin therapy versus insulin plus semaglutide versus insulin plus semaglutide plus dapagliflozin for about 52 weeks. And they aren't going to be outcome based. They're going to look at A1C reductions, and that's going to be their main outcome. And the reason I bring this up is not to say, to look for these in the future, but really these are sort of the more potent GLP-1 agonists that we are using currently. And as more data and more trials come out showing the significant weight loss benefits, I think that's where we're going to start to see these medications creep into the type 1 diabetes population more and more as it gains FDA approval for an indication for weight loss. And I could certainly see that sort of permeating the type 1 diabetes population from that perspective. So something to keep our eyes open for. So moving to the SGLT2 inhibitors, again, most of our data is in type 2 diabetes. This is the meta-analysis looking at all the 6 large renal and cardiovascular outcome trials, and I highlight the EMPA-REG and DECLARE-TIMI because we have some data with these same agents in type 1s that we'll talk about. And just something to mention, in all of these trials, about 70 to 80% of the participants were on statins already, and about 80% were on ACE or ARBs. And about almost 100% in the Credence trial, which was obviously looking at renal outcomes. And so when you look at major adverse cardiac events and you stratify the two groups by either existing cardiovascular disease or no prior cardiovascular disease, there really is maybe a little bit of benefit to those who have existing cardiovascular disease, but not much difference when they don't. So in terms of primary prevention, not strong data to support that use. Where I think that these really are going to be used in the future going forward is going to be in terms of the renal outcomes. So across the board, patients with or without cardiovascular disease, there's a significant benefit in terms of the SGLT2 inhibitors across the class. And so this is where I see these medications getting pushed on patients with type 1 diabetes, and we'll talk about obviously the associated risks that are with that. So moving into the data that we have for the SGLT2 inhibitors in type 1 diabetics, there's 3. There's the in tandem, which looks at sotagliflozin, and just to mention, sotagliflozin inhibits both the SGLT1 receptor in the intestine as well as the SGLT2 receptor in the kidneys. There's the EASE trial, which looks at empagliflozin, and then the DEPICT trial, which looked at dapagliflozin. So let's start with sotagliflozin, or the in tandem trial. So they randomized 1,400 patients. They looked at 400 milligrams of sotagliflozin daily versus placebo. Their sort of starting characteristic I wanted to highlight is their starting A1Cs were between 7 and 11%, and about 60% were on insulin injections. So the majority were on insulin injections, but still a good number of pumps, about 40%. And when you look at the actual reduction in A1C that you see, it's only about 0.5%, and their maximum sort of is achieved by 24 weeks of therapy. At 8 weeks of therapy, and is maintained kind of throughout. Where I think all of us sort of pause is we know there's an increased risk of DKA with these agents, and certainly putting these agents on type 1 diabetes patients increases their risk significantly in DKA. And do the trials that they looked at this, does that back that up? And the answer is yes. So when you look in the bottom right-hand corner, you see sotagliflozin versus placebo, you see about 3 to 4% versus 0.5 to 0.7%, which were all significant. And what actually makes me the most nervous is this middle bar of the treatment group, where you look at the patients who were on insulin pumps. 4.4% of them in a small trial had an episode of DKA. They don't have any data or information on whether these patients had DKA prior to enrolling in this trial. But certainly, whether they've had DKA or not, this is concerning to me. So looking at dapagliflozin in type 1 diabetes patients, so this is the DEPICT-2 trial. There was a DEPICT-1 that was only a European population. The DEPICT-2 included both the European and I believe it was from Japan. And again, A1C start points were 7.5 to 10.5%. They randomized to placebo, dapagliflozin 5 milligrams or 10 milligrams daily, and they had about 270 patients in each arm of the study. They followed them for 52 weeks, but the graph that I'm showing only goes out to 24 because the maximum effect was seen by them. And so when you look at this, the green, the lime green color being the placebo group with insulin, and then you see the dapagliflozin group, the treatment groups, both the 5 and 10 milligram groups, being pretty similar, but again, modest reductions in A1C of only about 0.5%. Interestingly, they didn't see any increase in hypoglycemia. And let's sort of focus in on the risk of DKA again. So they did not have standardized testing. I should have mentioned that for the previous trial with sotagliflozin. There was no standardized ketone testing. There was a little bit more sort of aggressive testing in this trial where they were supposed to test if any had any symptoms, and they were supposed to call the principal investigators if their ketone levels were above 0.6. And so when you compare the two treatment groups versus placebo, again, you see an increased risk of DKA. There wasn't much difference between the lower dose dapagliflozin and the higher dose dapagliflozin, so that's kind of interesting. But again, risk of DKA is certainly higher in the treatment group, so something to be concerned about. The last agent that we have sort of a randomized trial for is empagliflozin. This is the EASE-2 and 3 trials. They added on the EASE-3 trial to look at an even lower dose of empagliflozin. So they were starting out looking at 10 milligrams and 25 milligrams, and then they added in an even lower dose of empagliflozin at 2.5 milligrams. Sort of similar start points for A1C, 7.5 to 10% at enrollment. They did do more stringent ketone testing in this trial, which was nice to see. Where they did daily testing during their run-in period in the first 4 weeks of therapy, and then 2 to 3 times per week for the remainder of the study. When you look at the reduction in A1C, again, you still see pretty modest reduction across the board, both from the 2.5 up to 25 milligram dose. You see a little bit more benefit in the 10 and the 25 milligram doses, but you still see a pretty significant difference in the 2.5 milligram treatment group compared to placebo. What does that translate to in terms of DKA? And again, pretty similar with the higher dose empagliflozin group in terms of DKA incidence. Maybe a little bit lower in the lower dose empagliflozin. So maybe you could make the argument that this might be safer to use in this population, but obviously it was a smaller arm of the study, and so you have to take that with a grain of salt. Interestingly, they also had CGM data, and they showed time in range kind of at the beginning and compared it to the end of the study. And they found that there was increased time in range kind of across the board, about an hour per day with the low dose, and then about 3 hours at the higher doses. So certainly there's some improvement in glycemic control and probably reducing variability. But again, having to take that with a grain of salt, knowing that there's an increased risk of DKA is something we have to keep in mind for all of these patients. So again, kind of summarizing the SGLT2 inhibitors in type 1s, it's not FDA approved. It is approved elsewhere, but the FDA looked at the same data and said, nope, we're not approving this due to the increased risk of DKA, which I think is probably reasonable. There's only modest A1C reductions. There certainly is positive effects for weight loss and blood pressure, as we know. I think it was reassuring to see that there's no increase in hypoglycemia, and certainly can increase time in range. This can lead to sort of increased patient satisfaction in terms of their perceived glycemic variability. But again, does the benefit outweigh the risk? And I'm not sure that answer, we have that answer at this point. And I think I would lean more towards the risk does not outweigh the benefit does not outweigh the risk. And then again, there's no long-term trials looking at these medications for cardiovascular or renal outcomes, specifically in the type 1 diabetes patient population for reasons that we just laid out. These are pump readouts on the right here that I stole from Ann Peters at USC. It was a talk that I attended where she was talking about sort of the pros and cons of SGLT2 inhibitors in type 1s. And the top graph being sort of the pump before SGLT2 and the bottom readout being after adding, I think it was canagliflozin 10 milligrams. And you can see certainly there's less variability and much more time sort of at target. This is a patient, she stipulated and said, this is someone who has pretty much every tool available to her, very technology savvy, very intelligent. And And I think I would worry about putting a lot of our patients on these medications because they really have to be savvy about if they get sick, they need to stop these medications. If they're doing more frequent ketone testing to make sure they're avoiding going into DKA. And so there's just a lot of risk. And I think it's got to be a very particular patient who's pushing for this really before I would consider using them. So I know I sort of harped a lot on the fact that we don't have a lot of data. There's not, we don't have a lot of good tools in our toolbox, and it's not all bad. This is sort of updated data from the Swedish cohort registry looking at all-cause mortality, cardiovascular death, coronary heart disease, and hospitalization for cardiovascular disease. And you can see the blue lines being the type 1 diabetes patients having an increased risk of all of these things. But the gap is narrowing. And I think at least we can take consolation in the fact that we are moving the needle in the right direction. Is it moving as fast as we would like? No, probably not. But certainly we're moving it in the right direction, and we can be reassured by that. So just talking about, some conclusions, some highlights from this talk, glycemic control is paramount, I think, as we all know, to achieving positive cardiovascular outcomes in type 1 diabetes. But independent of A1C, type 1 diabetes really confers an increased risk of cardiovascular disease and mortality. Disease duration, I think, should be much more at the forefront of our thought when we're discussing, risk reduction with these patients, because I think we need to be more aggressive in longer disease duration. Hypoglycemia, we didn't really talk about that. There's not a lot of data for it, but I think as we really emphasize with the CGMs and these new closed loop pumps and really trying to minimize hypoglycemia, is that in and of itself going to show better cardiovascular outcomes? Maybe. I don't have any data to back that up, but certainly something that we can hope will show at least some benefit. Altered lipid metabolism in type 1 diabetes. So do we need different strategies? And again, I think the answer is yes. And do we need to be more aggressive with primary prevention? Maybe, but I don't think we're ever going to get the trials or guidelines to support their use in that manner. So certainly something that needs to be individualized when we're talking with patients with type 1 diabetes, and sort of, this is what we're thinking. We know you're high risk, but we don't have a lot of guideline data to support treatment and interventions from a blood pressure standpoint, lipid goals. We didn't even talk about aspirin prophylaxis and cardiovascular screening for like coronary artery calcium scores and the like, which are a little bit controversial these days. And so we can't forget about, adequate physical activity, healthy diet, smoking cessation, but certainly having a more in detailed discussion about these other sort of targets with our type 1 diabetes patients is really important. So as I mentioned, we just need more tools, and I don't know if we're going to get them. Unfortunately, now we have weak data for off-label use of metformin. There's some benefit to the GLP-1 agonist. As I mentioned, I think that this is going to permeate into this population because of the FDA approval for weight loss. And so I think that's where we're going to start to see these sort of trickle into the type 1 population. There's really no strong data supporting off-label SGLT2 inhibitor use in type 1. And obviously, as we talked about for obvious reasons, I think the risk outweighs the benefit. And one final point that I made, because we've talked with our cardiology and nephrology colleagues here at Madison, but watching out for these agents being started for non-diabetes reasons, right? So these are very popular in the heart failure world, and they're very popular in the chronic kidney disease world. And my worry is that, both at academic institutions and outside, these agents are going to get added because we think there's such a strong benefit for other reasons to our type 1 diabetes patients, and going to have bad outcomes in terms of putting them in the hospital for DKA or other issues. So certainly something that we need to have sort of at the forefront and maybe get out ahead of and talk with our cardiology and nephrology colleagues to make sure that this isn't happening. So at least it's on their radar. So with that, I will stop. Thank you so much for listening. Thank you for having me. And I'm happy to take any questions or comments that anyone might have.
Thank you, Mickey. That was an excellent presentation. So now Mickey will take some questions if any of you have.
Mickey, this is Jay Finling. That was a very, very nice review. Well, since GLP-1 agonists may be employed in type 1 diabetes because of weight loss, is there any evidence that cardiovascular risk is higher in obese or based on BMI? I mean, is there any relationship between cardiovascular risk and BMI in type 1 diabetes?
Not that I know, and certainly I can go back and look and see if there is, but I would expect that yes, there would be increased risk with obesity, causing patients in the type 1 diabetes population to have higher cardiovascular risk when they're obesity. I didn't look for that data specifically, but I imagine there probably is something out there in support of that, and so I think that's where we're going to start to see these agents used more commonly. And I think reasonably, that's pretty reasonable given the fact that there's not, sort of type 1 diabetes specific adverse outcomes. Yes, of course, we worry about, the nausea, vomiting, belly issues, but that's not specific to type 1s. So, yeah, it's a great question.
Mickey, this is Joe Shaker. That was a great talk, and I look forward to meeting you tomorrow. So I have a question about the extreme old. So if you have the type 1 diabetic who's fortunate enough to live into their 80s, is there a point at which statins no longer provide a benefit?
Yeah, so it's interesting that you mentioned that. There isn't data to support it, but actually in the guidelines, I left it out. But they mention for patients who are above the age of 75, if they're already on a statin, it's reasonable to continue it. For those who are somehow not on a statin, hitting the age of 75 with type 1 diabetes, they said it's certainly reasonable to have a risk-benefit discussion with that patient and decide, whether or not there's a room for adding a statin.
Is there just no data in that?
Unfortunately, yeah.
Okay.
Unfortunately, yeah.
I have a two-part question, Mickey. So is there a difference in glycemic control between Europe and US? The one reason is, the access to healthcare, in terms of, the supplies and, whatever else the diabetes therapies cost might be. So there is a difference between Europe and here. So does it matter, whether, in the poor control in US, you showed really under 30% full control. That's one. The other, I was very curious at aggressive lipid lowering therapy in Europe, while they have close to 30% smoking rates. Is that why they have lower? Because I think smoking rates are much higher in Europe compared to US. So is that why those societies have differed in the way? Because I thought maybe instead of asking them to quit smoking, just to give them a statin. I don't know. I'm just
It's a fair point.
differences.
It's a good point. I didn't look at that specifically, but yeah, it's a good point. Are they just sort of mitigating the risk with smoking by trying to be more aggressive with cholesterol management? Maybe. It certainly is reflected in the cardiovascular guidelines from the different societies in Europe. With regards to control, I think they are similar, at least looking at the sort of that German and Austrian cohort compared to the US, the type 1 diabetes exchange. I think A1Cs are fairly similar. And so, yeah, I think that it's fairly similar.
So there is really, it's really the how type 1 diabetes is rather than access to care. Right.
I think
That's
so.
what
I
it
think
would
so.
be.
Yeah.
Okay. Any
Nikki, great
questions?
talk. This is Ty Carroll. Could you just comment on statin use in younger individuals, especially women of childbearing age? Because certainly we get into 20 and 30-year-olds now with the recommendation of statin use if they've had diabetes for 10 or 20 years.
Yeah, it's a great point. Interestingly, it's not necessarily, I don't even think it's in the guidelines where they mention sort of that point of the women of childbearing age. It was in a talk by Bob Eckel, who's out in Colorado and does a lot of this work there. And he did mention that. I think I forgot to mention that. So thank you for bringing that up. It's a great point. So as we sort of maybe consider earlier statin use in women, given that they're significantly high risk of developing cardiovascular disease later in life, as we showed. I think it's a great point and something we need to be mindful of. So thanks for bringing that up.
Can I, Nikki, it's Joe Shaker again. Can I follow up on that question? So
Absolutely.
I had a little trouble seeing the slide because I had to switch to my phone for a while. And the risk in women compared to men. Now, is the risk actually greater or just the relative risk greater compared to women who aren't diabetic?
Yeah. So what I think you're asking is this comparing to other, so type 1 diabetes men and women versus women who have type 1 diabetes in the general population? Is that what you're asking?
Well, no, what I'm saying is, do women with type 1 diabetes have a higher risk of cardiovascular disease than men with type 1 diabetes, or is it their relative risk that's greater compared to women?
Got it. It's the relative risk that is greater. Yeah.
Okay.
Okay. Doesn't look like there are any other questions. So thank you very much, Vicky. This was a really great presentation. A lot of thoughts that were running through my mind. So, well, I think we all look forward to meeting you tomorrow. If there are no other questions, we'll have let Vicky sign off. Thank you all for attending.